We have not met for several months, as probably people who come regularly may have noticed. We are, of course, in the middle of a pandemic, and I would like to introduce Judy Davidson, who is our speaker today, which I will do in just a minute. But by way of preamble, I just wanted to say that I've had Judy speak at a number of my venues before, and including at Rady Children's, and she and I had been talking about her presenting this material for quite a while, and unfortunately we had to postpone, and here we are by Zoom. But I'm still delighted that we will be able to do this, and I just remind everyone that there are benefits to everything, and with Zoom we don't have to look for parking. So there are a few advantages. With that, let me introduce Judy. Judy Davidson Dr. Judy Davidson is a nurse scientist at UCSD, and she has, she's also a research scientist in the Department of Psychiatry, and her current research, as today's talk would assume sort of suggests, is that she has for some time now been studying the issue around suicide in clinicians and issues of workplace wellness. She launched the first nurse suicide prevention program with Drs. Norcross and Sid Zisuk here in 2016. That is at UCSD. And today she's going to talk both about sort of the data that she's compiled about clinician suicide and suicide prevention. So with that, I would like to welcome Judy and thank her again on behalf of all of us for agreeing to do this talk and to do it sort of over Zoom. Let me just say that at the end of Judy's talk, we will, as usual, have our open discussion, and Judy will take questions. And what I'm going to suggest is that we use the raise hand function on the participant screen. And so you just pull down your participant screen, and at the bottom, beneath the names, you will see 4 gray buttons. I assume many of us have now been doing this, but for those who haven't, if you don't have a raise hand button, you go under more and you will see a little blue hand. And if you raise that and unmute yourself, then Judy can call on people as we go. Otherwise, I would say while we're doing the talk, once Judy starts presenting, maybe we can all mute. If your neighborhood is like mine, it tends to be noisy in unpredictable ways, and that will improve the sound quality. And then my last sort of direction is that if you have a video feed and you're happy to be seen, when you speak in discussion, you can turn on your video. And then when people are finished making their comment, if you can take down your little blue hand, Judy will know if you have more than one comment you want to make, and they won't all sit up there. So that's it for Zoom instructions. And again, welcome, Judy. Thank you for coming, and thank you all for participating this afternoon. So with that, I'm going to turn things over to Judy.
Well, thank you very much, Mary. I'm going to share screen now. And hopefully you can see my slides. Yes?
We have got them up. Yeah.
Okay, good. All right. So I did dive into clinician suicide approximately 5 years ago. I was born and bred an ICU nurse, not a psych nurse, so I'm an imposter in this field, studying rapidly with my mentor, Dr. Sid Zisuk. He and I conduct research together on this topic and others, everything we do together and share together. He's sorry he couldn't be here today, but he did give me some data that we've just analyzed this week. Okay, brand new data about physician suicide that you'll be hearing about today. This all started because we had a cluster of nurse suicides several years ago, and it struck me as odd. And when I went to the literature, there wasn't anything in there about nurse suicide for many, many years in the United States. So I took it upon myself to start some research. hooked up with Dr. Zizek, Drs. Norcross, and a host of others, and we've been delving into this over time. So I'll talk today both about suicide and about strategies we can use to protect ourselves and our colleagues during these very stressful events of the COVID pandemic and social unrest. So I will pull that context in, and I have a couple little videos for you as well. So this is a sensitive topic, and it's likely somebody in the audience might have an issue with depression. If this brings up emotions that need to be handled, please talk to a friend or a colleague. Know that you're not alone. The 1-800 hotline is always available. And here at UCSD, we are so fortunate to have both a hotline by the psychiatry department during COVID, a brand new hotline that they put together for people who need extra help to get them into treatment. We also always have here.ucsd.edu, HEAR.ucsd.edu, with the phone numbers of therapists and Dr. Zizek right on the webpage. So with that, I'd like to bring you to this little video that my friend and colleague Laurel Prince made for an art exhibit when she worked here at UCSD. Now she's up at University of Washington. Let me see if it'll load directly from the slide. And this was made for nurses, but no matter what discipline you are, I'll bet that this will resonate with you. So didn't that make your heart rate speed up just a little bit, right? That video was made pre-COVID. If she had a mask and gown and face shield on today, it couldn't even be closer to the truth. So I have a little polling question for you. I don't know if Becca built the polls, but just if not, think to yourself, the answer to this question: which of the following is true about nurse suicide? ICU nurses are at greatest risk, followed by emergency nurses. Boomer nurses are at less risk due to resiliency offered by experience. Nurses with greater empathy have more suicidal ideation than others. Nurses are at greater risk than the gender-aged matched population. What do you think is the truth there? And the answer that we know at this point, after a longitudinal analysis that Sid and I conducted together from the years 2005 to 2016, the most current data we had at the time, that over all of those years, nurses were at greater risk than the gender and age matched population. There is some suspicion that empathy does have an issue with if you're not tending to resiliency and self-care, that you can burn out because of the empathic, the vulnerability associated with being empathic. but there are ways to mediate that effect. We have no idea about boomer nurses being at less risk, but we do know that nurses that kill themselves are slightly older than the general population. So this is definitely not true, number B. And A, we have no idea what type of nurse is at greatest risk. We're very fortunate even to be able to figure out that nurses are at greater risk because the occupation codes in the data set for suicide in the CDC, the occupations are hand-coded, and we have to do some fancy maneuvering to figure out who the nurses are in that data set. Between 2005 and 2016, if you see the red dots there, those are the female nurses, and the black ones are the male nurses, and the line across the center at 1.0 would be if they were equal to the general population. Hopefully you can see my mouse, that the nurses, female nurses, have been at higher risk the entire time. Suicide amongst female nurses is not increasing. It has always been bad. Male nurses were above the line most years, but it's been consistently above the line 2013 to 2016. And I've looked at the 2017 data, and that has held true. In these later years, we had a higher number of states participating in this data set. So this data set's truly more believable. It's nearly at 2017, all 40 states were involved. And prior, way down here, there were only about 18 states involved in this. So another question for you about physician suicide this time. Which of the following do you think is true about physician suicide? Physicians are at greater risk than the age-matched population. Female but not male physicians are at greater risk than the age-matched population. The risk of physician suicide has been increasing with the rise in burnout. Or physician and nurse suicide risk appears to be similar. Think to yourself what the answer might be. And nobody but you in this audience knows this because this is the data we just analyzed. It hasn't been analyzed for many years in the United States. And contrary to what has been found in earlier years, the answer is this. Female but not male physicians are at greater risk than the age-matched population. So this has been seen too internationally, where the risk amongst male physicians seems to be decreasing over time. No one knows why that is happening at this time. It may be because we've recognized burnout for many years now amongst physicians, and there have been strong actions taken. We don't know that for sure. That's just me guessing at this point in time. So this is the data that Sid put together this week for us. If you look at the bottom, these are females, and the gray is female physicians, and the yellow is female non-physicians. And we age match here to greater than 25 years old because that's when physicians enter the profession. Up here, this is male physicians and male non-physicians in orange. Now there's coded victim characteristics in the data set that we received from the CDC. We have their entire data set, all of the data that exists in the United States way back to 2003. And what has been really interesting to us with the nurses is that they are more likely to have a job problem known prior to their death by suicide than the general population. And they're also, female nurses are more likely to have a physical health problem. This is a key finding, we think, for this group. Then Sid put together the physician data the other day, and look at this straight across the board. There's an issue with job problems where nurses and doctors are more likely to have a known job problem prior to their death by suicide than the general population. So think to yourself at this point, what do you think could be true about this suicide and job problem? Being witness to repeated death increases our risk of suicide. Stressors of shift work increases clinician risk of suicide. Millennials are at greatest risk due to insufficient positive feedback. or job loss due to substance use investigation may be a unique risk to nurses. Think about that. And the answer here that we think we are seeing, the data set that we're using has investigative narratives from the coroner and the medical examiners and the law enforcement agents. And okay, so we took just the firearm deaths amongst nurses. There were 708 nurses over the many years that the data has been collected who have killed themselves using a gun. And in just those deaths, we began crafting a technique to look at the narratives. And in those narratives, we found something we were not expecting. We thought it was going to be exposure to death, right? That kind of thing. But no, it wasn't about this that was increasing our deaths. It was amongst nurses who died by firearms. There was a large cluster of them being investigated for substance use and substance use disorder, and they killed themselves due to the process of that substance use investigation, that they could not bear the thought of possibly being separated from their job as a nurse, and they felt they were being mistreated during being investigated for this physical problem. And I think the point we really need to bring out here is that substance use disorder is a disease, and the punitive nature in which it's handled in nursing really needs to change to save lives. So we are now going into that deeper with the entire data set and looking deeper into this issue about the death due to substance use investigations. And some of you might note that this is handled differently between our professions. Physicians are not punished in the same manner when it's found that they need help for this disorder. So it was known prior to COVID that nurses had more depression, anxiety, stress disorder, and suicidal ideation than the general population. So there's something inherent in our profession causing risk. And now, if you think about it, with all of this added on, this is one of our UCSD COVID rooms with our nurse, Mark Porter, a real nurse. You think about the amount of stress added by all of this. It can't be good. We can't ignore these risks during this time especially. Now more than ever, we have to care for ourselves because pandemics result in panic disorders, stress disorders, depression, and suicide. Physicians have been known for quite some time to have really high rates of burnout, depression, thinking of leaving the job. So given this context, we really need during COVID to act upon our evidence-based practices for suicide prevention now more than ever. This is a rare drawing done in 1918 by Egon Schiele, chalk on paper, a portrait of his dying wife, Edith, during the Spanish flu pandemic, which was the last time that we had something so bad like this happening on American soil with millions of people affected and all of these deaths. And during this flu pandemic, though, back in 1918, there was very little artwork of that period of time. It happened to coincide with the end of World War II, and artists were spending their time drawing war pictorials instead of the flu. Now, if you think about a few years from now, looking back at the COVID pandemic, what do you think the art's going to be about, right? We have an enormous amount of attention being made to our professions in healthcare and pictorials of us and the stress that we endure because of the pandemic. And if you think about it, here's another nurse in one of our COVID rooms, Angela Klinkhammer. They have a photographer up there in the COVID ICU, and these nurses have all willingly shared their pictures of us working in that environment. Here she is looking, hoping that somebody sees that she needs help in there. So a note about gender. This is a picture in Washington, D.C. about the flu pandemic. and you see two female workers hovering over a dead body. It is known, it is true that women are at higher risk of stress disorders, okay? And that nursing is a female dominated profession. Greater than 80% of our profession is female, and females in the physician discipline are increasing, right? And we cannot ignore this. That we're at greater risk to begin with. And now with this pandemic, we are on the front lines for real. And that time in 1918 and this time now is a time when we've had more than ever women on the front lines of this terrible situation under this undue stress. So we have to take note. Further, this is an old slide that many of you may have seen that are involved in disaster work or disaster preparedness, but it still holds true today. I received it from the president of the American Psychiatric Nurses Association. She said this is still true today, even though it was built 20 years ago. That in disasters, you have a period of time where you have, this is emotional highs up here, and emotional lows and time. And you have pre-disaster, there's some warnings and threats, and then a disaster hits like our COVID pandemic, and your adrenaline rushes during the time of heroism, right, in the beginning, and as you're gearing up for battle and the fight against this disaster, and we're gonna save lives, right? And then you get to a honeymoon phase where now we finally got all of the equipment we need, we know how to deal with this, and we know what we're doing, we've got strategies for care, and we're working together as a well-oiled team, right? Well, then what happens is disillusionment and despair as time goes on and the problem does not go away. Where do you think we are right now? We are coming into this phase of disillusionment. This is the period of time, and I think, Mary, we had to delay this program, and I think it might have been for good reason, because now is the time we really need to look at prevention techniques and strategies and take them seriously. We are right now at the greatest risk, okay, for losing colleagues in the profession due to either burnout or suicide. It's a real risk, and we need to pay attention. So then I'd like to move into coworkers ill at home, and I have to declare and make this declaration that I have a slightly different take on this than what we've heard both through our town halls and in the work environment. The worst thing that you can do for somebody at home quarantined with COVID is to leave them in isolation without contact. It should not be a secret. Now, how do you deal with the fact that you've got a colleague at home in quarantine and maintain privacy under privacy regulations? Well, the HERE team has written up a protocol that we're hoping to pass through the executive committee that has been approved by HR Compliance and Risk, but it has to go through the executive committee to take the approach that once the manager finds out an employee is ill and in home in quarantine, reach out to them and say, your coworkers will want to support you. How can we best do that? Right? And phrase it in the positive. The doctor that died in New York of suicide was home, separated from her team after that event, right? With no connection to her team. We can't leave these people alone in their thoughts of whether or not they're going to die from the illness. We need to increase connection with them to prevent the bad thing from happening at all costs. One of the greatest risks of suicide is loneliness, isolation, feeling disconnected, feeling like you don't belong. So we do need to connect with our people at home. Today's town hall, they announced 2 to 4 employees a day are being diagnosed positive in our own organization. So we do need to take note. We have had nurses and doctors positive, right? We have to take note and take strategies. Our own Dr. Ilana Iglowitz from the Department of Psychiatry published 2 very important papers this year on death and bereavement during the COVID pandemic and how to deal with death and bereavement. The HERE committee, Healer Education Assessment and Referral Committee has developed a protocol that can be used in case of the death of one of our employees during this time. So we're prepared and at the ready to support HR and work in collaboration with managers if that occurs. We pray it doesn't, but we're prepared. Elena teaches us there's 3 forms of grief dealing with death. There's acute grief, acclimated grief, and then there's, oh dear, I'm gonna blank on the word and somebody's gonna help me, complicated grief. So then in acute grief, usually you don't need professional help to get through that. You're at a loss and you're sad and in despair and it feels bad, but usually friends and family can help you through it, but you need your friends and family and social connections to help you. Then you become acclimated to the fact that the person is not here any longer, but you can get through your daily living almost normally. You still feel the loss, you still feel the pain, but it doesn't stop you from living. Those that go through complicated grief, it affects their activities of daily living. They need professional help to get through it. If we lose a colleague, we are going to have to manage that grief so that the rest of the people around them can continue the work at hand despite the loss of a colleague. We can't ignore the situation or put it under the carpet. We need to help recognize people who are having a problem dealing with the loss and getting them the help they need. Fortunately at UCSD, we have all of the resources to help people. We have the active psych hotline, we've got the HERE committee and referrals, we have EAP and the benefit for benefited employees. So we have everything we need. We just have to refrain from putting it under the carpet. There are other proactive suicide prevention strategies. The physicians right at UCSD developed the first physician suicide prevention program in the country that has been, the American Medical Association recommends the program as a best practice in suicide prevention for physicians. Our own Dr. Moutier that trained at UCSD is now the medical director for the American Foundation of Suicide Prevention. And she has been helping organizations all around the country replicate the strategies tested right here. How does it work? It's very simple, elegant in its simplicity. The dean or the chancellor sends an email to doctors once a year and trainees. Then Patty Mason or Margarita Baguette send an email out to staff and nurses once a year. We put them out in batches by 500 so that therapists can keep up with the work from people who screen positive. They send them an email saying, please take this screening as a matter of self-protection, right? As a matter of self-care. And no one will ever know you took the screening, and you can remain anonymous all the way to treatment if you need it. So then the AFSP works as a third party to manage the encryption on the program. The email is sent, you do your screening, it takes about 5 minutes. It goes through an encryption to AFSP, it's automatically scored. If it scores moderate or high, a therapist at UCSD gets that message. They don't know who you are, it's encrypted, but they contact you through the computer. You engage in dialogue through the computer, and if you want to, you can come in and be personally treated and referred to mental health treatment if you need it, or you can remain anonymous and work through the computer. You can do computer, phone, or in person, all on your own accord, so that you can remain anonymous all the way through. We think the fact that it's proactive and anonymous is what makes it work. We started doing this for nurses and staff in 2016. We're the only organization for several years doing it for nurses and staff. Now we're up to 60 nurses a year with expressed suicidality that we're finding at UCSD and referring into mental health treatment. We have sent hundreds of clinicians into mental health treatment successfully over the past 10 years. And because of this work, the American Nurses Association has now started a task force to look at suicide prevention in nursing, and they are recommending that organizations around the country do the same thing. So see me, hear me, speak to me. This is a beautiful collage done by my friend Linda Lovestall. We call her our lead artist in nursing. And she took all these words about feeling cared for at work and put them behind this collage: hear me, see me, speak to me. And this is really an important suicide prevention technique: hearing that others are in pain or suffering, seeing that our colleagues need help, and speaking up to them as if you might be the only person who noticed, not letting someone go by as being upset without taking notice and taking action. Dr. Zizuk is launching a brand new peer support program. Many of you on the call today are part of our peer support team, and we're going to be offering certification in peer support. We offer an initial training for Tier 1 level peer supporters, and then 12 consecutive weeks of updates in training on specialized content to help with peer support. And the peer supporters, we hope, will be strong enough with their knowledge and with the network of each other to be able to recognize colleagues in distress and have the resources available to refer them into treatment, talk to them about getting treatment that they might need to help save lives during this difficult time. We'll be running another cohort of training in September, so look forward to that if you're interested in becoming a peer supporter. But if we all, each and every one of us, just reaching out to somebody who had a bad day and saying that you noticed and you care can be a life-saving measure. It's when people feel alone that they tip over the edge. And here you see two colleagues working in a COVID isolation room. Hear me, see me, speak to me, right? With a walkie-talkie and looking out for help past those glass doors. I have one more video here I'm hoping you'll like, and this was made by some of our UCSD colleagues in collaboration with the American Foundation of Suicide Prevention, and it's about how to speak up with medical trainees who might be at risk.
Medical training is challenging.
It can be frustrating.
Exhausting.
Overwhelming, especially when things pile up on you.
My marriage is coming apart. I took out $183,000 in loans.
I made a mistake, a bad one.
Sometimes I feel like I'm in over my head. I just don't feel prepared.
Sometimes I think the real mistake was thinking I could be a doctor.
We all have our ups and downs, but if somebody starts acting really down,
Not able to sleep or sleeping too much.
Shutting her friends out, giving her stuff away.
If somebody just doesn't seem like himself.
Not doing things he used to love.
Showing up late, not getting things done.
if somebody starts acting reckless or irritable.
Yelling at nurses, snapping at patients.
Drinking too much.
He might be feeling burned out, or depressed, or hopeless.
People who are smart and talented, they get overwhelmed just like anybody else.
And when they do, they may find it even harder to ask for help.
Medical students and residents have higher rates of depression and burnout than other adults.
They have a higher risk of suicide, too.
That's something we all need to understand, the risks, and how to look out for ourselves and each other.
And when it happens, people say, I had no idea. I thought he was just upset.
I thought she'd get over it.
I wish he'd come to me. I wish he'd said something.
I wish I'd said something. And now it's too late.
Suicide can be prevented. If someone you know is acting differently or really down,
don't assume he'll get over it.
Say something. Say, are you okay? How can I help?
The best way to prevent suicide is to show you care and get the person the help he needs. So don't be afraid to ask straight out. Are you feeling so bad? You're thinking about taking your life?
People want someone to ask. They want someone to care. Faculty, peers, friends, anyone can ask.
Are you thinking about killing yourself?
And if she says yes, or maybe, or sometimes, here's what you don't say.
That's crazy.
One mistake isn't worth killing yourself over.
That's not going to solve anything.
What you do say is, I'm sorry you're feeling so bad. How can I help?
We'll get through this together. Let's get you some help.
Assume you're the only one who will reach out and get this person the help she needs.
None of us should be ashamed of getting help.
Getting help is the strong, professional thing to do.
Let her know she has options, that there are people she can talk to.
Let her know she can always turn to you. Make sure she has the National Suicide Lifeline number.
And help her find someone she can talk to. Someone who knows how to help.
Ask the Dean for Student Affairs or the Program Director.
If you think she's about to hurt herself, don't leave her alone.
Take her to the emergency room. Call 911 if you have to.
We all get down. We all have our bad days. But sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Are you thinking about ending your life?
Don't wait until you're sure. Trust your gut.
It never hurts to ask. It never hurts to care.
It can make a big difference.
Any one of us can make a difference.
All the difference.
In someone's life.
Yes, that's beautiful, isn't it? I almost cry every time I see that little clip. And I'm going to bring you even deeper into this. A friend and colleague of mine, Dr. Sharon Tucker at The Ohio State University, we're working together on the American Nurses Association Task Force, and she took me up on a challenge. I said, there's hardly any information out there. Like, what nurses always ask me is, how do I actually say the words to somebody if I think they're at risk? So she prepared a little bit of background information, put it up on their website, but she also created 8 videos of all different scenarios. And I'm going to show you one today, and then you can go back later if you're interested to this link and see the other 7. So it's important while you talk to somebody that might be at risk to show caring, listen, just let them talk, show empathy, really get in there about caring for what they're going through. Paraphrase what they're telling you. I hear that you're in pain. I hear that you're feeling depressed. They'll correct you if you're wrong. Okay, name the feelings and then be inquisitive. Tell me more. I want to learn more about what you're going through. And make sure when you're talking to someone, if they have rumination where they can't get bad thoughts out of their head, they talk about self-harm or hint at it or answer the question, yes, I've thought about harming myself or killing myself. If they have problems with impairment, or they actually request help. Or if your hair is standing back on the end of your neck and you say to yourself, this is more than a friend can deal with, I need help, I can't do this alone, this person needs help, make sure you refer them to a real mental health provider. Okay, so let's see if we can get 3 out of 3, one of Sharon's videos to come up for us today. So this is the site. Of course, their legal counsel put in a whole big disclaimer about all of this, and then there's these 8 videos that you can choose from. Let's take, I think I'm gonna take MP and MD colleague, and let's play this.
Hey, Dr. K, thanks for staying after the meeting today. I sent you that private chat because I could tell you were struggling, and I'm just wondering if you would be willing to talk to me a little bit about what's going on.
Yeah, thanks for checking in, Nancy. I really appreciate it. I just really didn't want to disappoint anyone, but I feel like I'm failing. I feel like I'm failing at everything. My family's angry. I'm never home. I can't find time for them or for myself anymore. I don't even want to exercise or go to church or even walk after I get home, walking the dog. I just want to end this.
Yeah. Wow. You sound like you're feeling really very alone and really very isolated. And I want you to know I'm right here. And I'm really glad that you stayed and that you were willing to just tell me that. That's huge. And I know it's really hard to problem solve when you're feeling like that. I'm wondering, have you struggled like this before? Like, have you been depressed before?
I've had some history in the past with some depression and some anxiety, but with this whole situation, it's just gotten so out of control, and I don't know where to go or who to turn to.
Well, and are you feeling like you could hurt yourself?
I thought about it, but I haven't, I love my family so much, and I couldn't afford to do that to them. But there are days where things just get really, really overwhelming.
Okay, so you're telling me that you are having some thoughts. You do at the same time see that you have people who care about you, and that's very positive. Have you, when you're having those thoughts, do you feel like you have a plan?
I've thought about things before. I don't own a gun. I know that's like one of the first things they have in medical school.
It's tough as providers sometimes, because
there are just some days where I just want to go to bed and just not wake up.
Yeah. Wow. Those are such tough feelings to have. They really are. And it is really difficult to walk through those feelings. One thing I know about that is I want you to know that I'm right here with you. And I want you to know that people do struggle. And I haven't had your struggle, but at the same time, I want you to know I'm here. Have you ever tried to kill yourself before?
No.
Okay. And here's what my thought is. I'm wondering, I do know that we have crisis care from employee assistants who are willing to come into a web conferencing session like this. And they know a lot more about like how to walk through this with you than I do. Would you be willing if we could just add somebody into this conversation right now?
Yeah, absolutely. I think at this point I'm open to trying.
So you could see how she did care and listen and show empathy, paraphrase back what the doctor was telling her to confirm, is this what I'm hearing? Tell me more and be inquisitive, but then link her up with resources right away when she realized the risk was there. And she knew who to call. So that's an important thing at this time. We have a slide to give you later that you could cut out, put in your back pocket, or enter into your phone all the different numbers we have at UCSD for getting somebody help. Okay, so does a program like today's program work, right? I'm going to tell you, that's my phone at work. That's my real desk, my real teacup, my daughter when she was younger. One day the phone rang. And the nurse at the other end of the phone, she said to me, Judy, I need to get a hold of one of those hair therapists. How do I get a hold of them? So I gave her the phone number. I said, why? She says, well, I'm working today with a suicidal physician. I said, oh, well, take care of it. I'll call you later. So she called the hair therapist. They got the person taken out of practice for the day, replaced in practice, got the person into treatment, went to treatment, came back working fine, but you probably want to know what happened. How did she know? How did she even know to call? So I called her back knowing she would want to be debriefed after she must have had an odd day if she was calling me for help for a suicidal physician and might need a little help herself to debrief past that moment. And I called her and I said, how did you even know? She said, well, I was watching this doc day after day, getting more and more despondent, getting more and more behind in work, never catching up and leaving thinking that the work was never done and just more and more irritable. And I knew it because I knew that we had the program because of the presentations you and Dr. Zizza had been giving, because of the screening Margarita Burgett had asked us to do yearly. I did the screening myself, so I knew what the questions were and I could see the problems in this doctor. And I just asked the question, are you thinking of killing yourself? And he said yes. So talking about suicide does not cause suicide. Talking about suicide can actually save a life, as it did in this case, where the nurse actually spoke up to the doctor, got help right away, did not leave the doctor, and the doctor went for treatment, and the depression was effectively treated. So right in our own hospital, this is not just an academic exercise that could happen somewhere. It's right our issue, and it worked. I want to ask you another question now, kind of get you more engaged back in with me after these videos. Which of the following is true about method of clinician suicide? Physician completes suicide most often by firearms. Nurses and physicians use pharmacologic poisoning most often due to access to drugs on the job. Female nurses use drowning most commonly as the method of suicide. Or males in both professions die most frequently in suicide by hanging. What do you think the answer is there? Okay, so physicians complete suicide most often by firearms. Male nurses also complete suicide most often by firearms. And surprisingly and concerningly, the use of firearms in female nurses is rising. I've noticed a rise every year since 2015, 16, 17. 14, 15, 16, 17, the rise in nurses using firearms over pharmacologic poisoning is increasing. So it's really important for us to know that if we have a depressed colleague and they have a firearm at home, that firearm should be removed from the house, okay, while they're getting their treatment. This is not a statement about gun control or whether people should have guns or not. It's a known fact if you remove the gun from the house of a depressed person, they're less likely to kill themselves. So we need to know that as a fact for ourselves and our colleagues. And the question you saw in the last video, or the way she brought it up, I don't have a gun, one of the questions to ask someone who's actively suicidal is whether or not they have a gun, and then suggest the gun be taken out of the house. Okay, so we do, the second on the list method is pharmacologic poisoning. What we're finding in our studies, which is contrary to popular belief, is that it doesn't appear to be access in most cases. Yes, there are some neuromuscular blocking agents from the operating room that are diverted and used for suicide, but that's a small number of cases in proportion to the number of cases where people are using things like Tylenol, right? So that is in your medicine cabinet at home. So we're beginning to think it's more about the knowledge to use drugs in a lethal manner than access to the drugs at work that are being used for a method of suicide. This is the list of referrals that I told you we'd make available to you that you could key into your phones in case you ever see a colleague that needs help, so that you'd be, at the ready to get them the help they need. And then also the list of triggers for referral. And I know there's some sensitivity about the word triggers, but I haven't figured out how to replace it yet in a meaningful way. But when should you really call it and get somebody more help than a friend can offer? And I'd like to put this back on a positive note now before we wrap up. This is a painting done of a nurse by a nurse at work at UCSD Jacobs. And I look into this nurse's eyes and all I can see is resiliency. I mean, if you look at her, she looks so strong, right? She looks like a poster child of resiliency. There are so many evidence-based ways for us to stay resilient using mindfulness and meditation and self-care. It's not just about the yoga mat. It's about clearing your mind of the clutter of the crisis and to remain resilient. Social connections, even if we can't be physically together. Making sure no one is alone. So focusing on resiliency skills is another suicide prevention technique. And some of us end up with post-traumatic growth instead of post-traumatic stress. And those with post-traumatic growth are those that focus on resiliency and take self-care seriously during difficult times. Here's another one, a modern day example of, I think, Rachel Stokes, a nurse up in the 3GH ICU, the COVID ICU. She looks the embodiment of resiliency. This is at the end of her shift saying, I love you all, you're amazing for the help you gave me today, right? And this is what we'd like to see instead of the worst case scenario we've been talking about. So this is my last slide, and I just want to encourage you all to do your own risk screening today. It helps you in two ways. It helps you to either know you could use a little help or that you don't. And it could help you like it did that nurse that called for a doctor in crisis. It could help you remind yourself of the type of things that might be signals of risk. So that it familiarizes you with the risk-related questions. Do the screening. You go to the here.ucsd.edu website. There it says Start Questionnaire. You make a private encrypted password and ID. Don't make it something with your name in it if you don't want to be disclosed. And it only takes about 5 minutes at the most, and you're done. So with that, I'm going to close the slides out and we can open it to questions.
Great. Thank you so much, Judy. That was really, oh, sorry. I don't need to be hidden. That was really so wonderful, very moving and really very practical and helpful. So just a reminder, I think Judy is going to use the participant list. So if you have a question or a comment.
Okay, so Chris Matthews, I want to thank you, Dr. Matthews, for your addition to the resources there. That the Physician Wellbeing Committee is a 24/7 resource, and CMA also has a 24-hour anonymous physician assistant line for doctors in distress. And from what I understand, the CMA has made those resources available free of charge, right, Dr. Matthews? They had made a pledge to make sure that doctors could receive the treatment they needed without a cost.
That's correct.
Yes, which is an amazing amazing coverage for physicians. Veterinarians as well, they've replicated the HERE program that we started at UCSD, the interactive screening profile for veterinarians. So the entire group of veterinarians takes the screening, and they're using third-party contract mental health treatment so that they can take the treatment through Zoom, right? Third party, which is a very, very unique approach and just started this year.
Terrific. Okay, so let's open it up for general discussion. Comments, questions?
Or challenges. It's okay to challenge anything I said. 25 years in the ICU, I've got a thick skin.
Okay, I see Leslie and Chris both have hands up. And you decide who you want to start with, Judy.
Oh, there, I see. Okay. And how do I address Leslie?
You can just talk.
Yeah.
Leslie, do you want to go ahead and start?
First of all,
I can imagine I'm speaking for many, if not all. Just thank you so much. That was so moving and also informative and enlightening. So much appreciated. You do great work, and
thank you.
As does Sid. I'm just curious if you have access to or awareness of any cross-cultural data. Other countries that use kind of a Western medical model. I'd also be interested in knowing if other systems of medicine, Chinese medicine practitioners or Ayurvedic, if other countries that practice other paradigms see this issue as much.
In nursing everywhere, every country it's been studied, nurses that are at higher risk. And in socialized medicine, they can even track the link between whether or not you were in treatment because their data is all connected, Yeah. So like in Denmark, it wasn't related to therapy, right? It's not that the nurses were missing therapy or, you know what I mean? It's not because of access to treatment, it was something else, right? That's why I'm really getting into this whole issue of the job issues. What are the job issues? And I cannot wait. We're just embarking on the whole data set. We did that little bit of 700 deaths, and now we're looking at the whole rest of the data to see what is it about those jobs that we can find in the narratives that are increasing the stress. We know from the HERE program, we analyze what's tipping people over the edge. When somebody does their screening, it's anonymous. We have no idea who they are or where they work, none of that. But we do ask them, what are your stressors? And a lot of it is work. It's the work compression, shift work, the role conflict for families. There's a lot of that going on. Workplace violence, violence from patients, violence from patients' families, and then the bullying that goes on between us, right? Is a large part of what's tipping people over the edge at UCSD that we find through the HERE program that needs to be addressed.
Wow, thank
you. Yeah. Chris, do you would like to comment?
Yeah, thanks, Judy. I want to also thank you for your many years of being our local champion from the very beginning when the institution started to deal with this. And I think one issue that's really probably more important now than before the pandemic is the whole contribution of moral distress and moral injury, which I don't think, well, I certainly hadn't appreciated until recently, where doctors and nurses and other health workers feel themselves put in a moral bind. And like all of these doctors and nurses that are being interviewed on TV that are working in these ICUs and ERs, where they're feeling unappreciated, overwhelmed, hearing mixed messages from leaders, both within their institutions and in local government. And that leads to a whole cascade of adverse outcomes, from burnout to depression to suicidality. And the other major category I was just going to mention that I had to step off, I don't know if you mentioned it, but overlap with substance use disorder. Yes. The importance of alcoholism and drug abuse, and many times people with this as an underlying disorder are also at heightened risk for suicidality.
Yes, definitely. And the pandemic and social unrest will increase the use of substances amongst those that were already at risk. So we can anticipate an increase in substance use disorder. I've been curious how the treatment programs are working now with social distancing. If they can get the treatment they need in the way they need it at this time. And I am so sad about the way that the state of California treats nurses. If you have a DUI as a nurse, you just written your ticket out of the profession. They make it very difficult for nurses to go through treatment and keep employed. The state of California encourages nurses to leave their jobs when they go to treatment, and then they don't have the money or insurance for treatment, right? So it's a catch-22 situation. I've had nurses that are suicidal contact me from around the state after they've read our papers on suicide, telling me about their suicidal ideation caused by the way they were treated by the BRN or their employer. Yeah. Yeah.
Yeah, I just wanted, Judy, this is Mary. I just wanted to second what Chris said about moral distress, even prior to the pandemic. Those who work certainly in clinical ethics and certainly in nursing ethics have known for decades that moral distress, feeling that there's no way forward to sort of act in a way that allows you to provide the kind of healthcare that you feel, or to operate in a way that you feel is in line with sort of your own values or even the professed values of the organization. And certainly at Rady Children's, we've been using our ethics consult service to do moral distress consults to try and talk people through sort of identifying what the moral conflicts are, and using the sort of moral distress mapping tools that Denise Dudzinski and others like up at the University of Washington have used. But I think right now in the pandemic setting, that is, I think we're seeing that just almost on a national scale, that you don't have the resources that you would normally have to provide even a minimal standard of care.
Well, just think about the catch-22 that we're under with our financial situation. COVID has wreaked havoc with the budget of every healthcare organization in the country. Traveling nurses have all been let go from their jobs. It doesn't mean the work stops. So what is happening? The nurses in those COVID ICUs and COVID units that are just beaten down to almost nothing with their continued service are being asked to do overtime every day to staff the units. We cannot hire because can't open positions if you don't have money, right? So it's a catch-22 there. Do I stay home and take care of myself, or do I come in and take care of the patients who need me? As an administrator, what do? Do you open the positions even though it's going to put you further in the hole, right? Or do you just hope you can get people to do overtime?
Well, and I think a lot of the things we've been talking about too in terms of resilience, after work, one can't go out with one's sort of fellow nurses or physicians or the team and kind of debrief or laugh or just sort of be together, just like when we talk about exercise and all these other self-care things. Quite frankly, speaking for myself, a yoga class at home in a room is not quite the same thing as going out and being with a community. So I see also we have a question or a comment from Anna.
Hi. Oh,
Anna.
You guys can't see me.
Oh, there you are. Hi.
At SDSU, and I was wondering if there's anything that you guys wish you would have done or known before you went out and applied for a job anywhere. Because personally, I want to be a pediatric nurse. So I was also kind of wanted to touch on like moral distress and that, but that can be addressed in a different question.
So repeat the question. Yeah.
If there's anything that you wish you would have like done or known before you entered the workforce.
I didn't realize I was a first responder for many years. I thought I was an ICU nurse. Like, it never occurred to me as an ICU nurse that I was a first responder. When the fires hit in San Diego, we were told, at that time I was working for another organization, and we were told, now as first responders, you're going to come in whether your job is needed that day or not. You may be watching somebody's kids out, you know, instead of doing the work you normally do, right? But we're going to put you to work. You're a first responder. And that was the first I thought of myself as a first responder. I think right now the experience that our students are receiving about what it means to be a doctor or a nurse or a therapist is very important to them as the world is chaotic. These things are going to happen over and over again. How many pandemics have we had? Ebola and SARS and, now the COVID. So we're going to have these situations where we need to act as first responders. And I think the lessons here are important for people just coming into the profession. I wish that more of the organizations were open to having students within our walls during these times. UCSD and the VA were the only two organizations allowing nurses in during COVID, nursing students into their buildings during the first phase of the pandemic. But what a better learning opportunity could there be? More hands up there, Mary? Let's see.
I'm not seeing any. Other thoughts, comments, questions for Judy?
I would challenge
myself. I'm hesitant. I'm unable to find where to do the hand raising.
That's okay. Go ahead, Kim.
All right. Yeah. I just want to make a comment. I teach nursing, and I think one of the greatest difficulties that I'm seeing with both my students and also with my peers from ever is that from the get-goes, nurses are socialized from the very youngest point to literally take one for the team. All right. They are socialized that way. And I feel that what I see with all of when we say, they feel unappreciated, I think it's not just that, but nurses are so socialized to this, they don't know how to step back from it. They don't know how to not be doing it, and then they will do it to their own destruction, And we see this over and over and over again. And if we as organizations, as a society, don't take a more protective position with this precious resource, the nurses themselves have been socialized from the beginning to do this. We often say, that no, becoming a nurse isn't like, this is not a job. This is like being a priest. You're ordained. You are that whether you're on the job or not, no matter where you're at.
Yes.
And that is one of the greatest fears and the dangers that I see in our current time, is that, just like you're mentioning about them continuing to be asked to take additional shifts on beyond past human endurance.
Right.
And wow, how do we stop that?
This is the year to stop, buck up, and take it. This is the year to stop it.
Yeah.
Of all years.
Yeah. And so all
that and do focus on the self-care. Otherwise we'll end up like Laurel Prince in the video.
Yeah.
All of us, not just nurses, but all the disciplines.
Right.
And we definitely need to do that. So I want to ask the team, what do you think about this? I heard on Town Hall today, Dr. Mendel, who's in charge of the COVID ICUs, he's a brilliant man, and he's so giving of himself, helping in Tijuana and El Centro, and it's just amazing what they're doing. But he's figured out rotations for the faculty and trainees so that they don't end up for months and months on end. He knows this is for the long haul now, right? Should we be doing that with our hospital staff and nurses? Should we rotate them out of those units and bring other ICU nurses in? It's been 4 months now, right? March, April, May, June, July, 4.
Yeah, we're actually into the fifth. We're into the 5th month.
Right. Should we rotate them? We've got 7 ICUs, 2 of which are dedicated to COVID right now. 1 down at Hillcrest and 1 in La Jolla.
Well, I actually, Judy, weighing in here, from an ethics point of view too, I think one of the things we're trained to do generally in thinking about healthcare in this country is, and this is picking up on what Kim just said, is nurses are socialized to give and give and give. But in this country, we're socialized to think about every problem as an individual problem. if Judy would work harder, or if Kim would work harder, or if Leslie, I'm just looking at the people up on my screen who I can see, would just work harder, things would go better. You got to take a hit for the team. But it seems to me if we take even half a step back, you can see that what COVID has revealed, and this has been pointed out, I think, in many, many directions, is that we have a patchwork healthcare system, and that these issues cannot be dealt with on an individual basis. So I'm really happy to hear, Judy, you say that, you know, Dr. Mendel is figuring out something as simple as a system so we rotate people off, we rotate other people in. The other thing, of course, is we need to think about staffing and adequate PPE and so on. Now, in the middle of a pandemic isn't necessarily the time when we can address sort of all of those things. But I do think we're really seeing some of the institutional and governmental failures, because what we're trying to do is to solve, well, what's a global pandemic, but even if we think about it just as a national problem in our healthcare system, with individuals either doing more yoga or a second glass of red wine, although I read the other day they're reducing the amount of wine that's apparently good for you, so forget the second glass of red wine, but maybe more yoga or, you know, more walks outside. But while those are good for all of us as individuals, and I don't mean to discount the importance of those things, I would just like to ask Judy whether you think that any individual efforts are going to be able to deal with this if we don't have institutional support and kind of wider structural supports for rethinking. I mean, you can't ask people to step away if actually they're going to lose their job or they're going to get pressure from nursing supervisors or from hospital leadership to be doing those things.
Right, we need a balance of individual, there are individual responsibilities for self-care, and then there are organizational, and at a national level, the professional organizations need to step up. So like the Joint Commission did stand up and got rid of documentation standards during COVID that they knew that would take too much time away from the nurses and doctors away from the bedside, because putting on the PPE takes time. Taking it off takes time. Where are you going to get that time? There's no more extra humans. The same exact amount of humans are taking care of those people with less time, right? So they said, you know what, we're going to take these standards and put them on hold for a while. And so that it creates a little bit more time for you. Now, maybe we could get those standards gone forever, right? Like, why is that? If it worked during COVID, right? Maybe we could do that. The whole thing with taking the IV pumps out of the room, we had to, that was a big fight to get allowed to do that. But we were able to do that that's an organizational decision at the organizational level, right? Do we allow temporary staff and per diem, or do we ask for overtime? Right, those are organizational decisions. How much overtime should somebody be allowed to do, or how many should you be allowed to ask for? Because even the act of asking somebody causes that moral distress when they have to choose between their husband and their children at work, right? Because they value their children and cannot choose them because their boss is saying, we really need you, we're desperate, this is a crisis. For the fourth month in a row. My
puppy has been at home for 27 and a half hours. Right?
Yes, so there is a layer of organizational issues that need to be tended to otherwise, and we're so thankful to have Lynette Cedarquist right on the command center, right? She was positioned nicely at the command center and sticking up for what's right for the employees and the organization, and thinking through those ethical situations very keenly. We were very lucky to have brilliant people in the lab who came up with all the testing, and we have the fastest turnaround in testing in the entire county. So that when you say, but it took me 2 days, well, it takes somebody else 7 or 10, right? So we are so lucky for that, right? So we have had an organizational focus that we could be proud of. There are certain things that I don't agree with, but there are those ethical value-based decisions, right? All the ethical, for me, I think we should have a greater emphasis on disclosing who's home and sick. getting their permission, gaining their permission to do that so we can support them. And others don't see that same value. They value the privacy greater. So they're not wrong, I'm not wrong, we just see it differently. But they are moral, morally laden value decisions, right?
We could ask the people who are in quarantine whether they give permission for their information. I mean,
right. Instead of assuming that privacy is their desire. Like even if you go to family presence on rounds data, my back history is in critical care, and I did a whole, systematic review of all the articles on rounding. And in every single time when families were asked what they preferred more, information or privacy in a ward setting, right? They said, we'd rather have the information. It's okay if our privacy is leaked as long as we're kept up to date, right? So again, the people at home in quarantine might actually prefer having their case known to their colleagues so that they get supported. Think of how many nurses and doctors travel to get these jobs and their families are somewhere else, right?
Or even the ones whose families are here, but that nurse or physician is living in the garage, or they're living, in Mission Valley in a motel someplace.
Right, in the hotels, alone in their thoughts.
That's right.
Yes,
yeah. So we're getting close to the end of our time, but I'd like to stop maybe and see if if others would like to sort of weigh in here or get information from Judy or make comments, particularly sort of what you've seen during COVID and what might be helpful. I'm giving Judy an in to sort of observation and comments that people might have in terms of taking these programs forward and also communicating the access to these various programs.
If there's no comments, I don't see any comments in chat except for thank yous, and thank you for the thank yous. Make sure to do your risk screening at here.ucsd.edu. Only takes 5 minutes. You might be surprised at an answer or two, and then you'll be able to recommend it to others that might need it, right?
Right.
Yes, take note of our resources and be thankful and grateful for everything we have at UCSD to support our staff and colleagues. If you'd like to become a peer supporter, let Sid or I know, or just watch out for our mass blast when we start up the next cohort in September. If you like programs like this, it'll be a lot more programming similar to this in nature. And I'm so glad to meet all of you today. See you again.
Thank you so much, Judy. I really appreciate this. And as somebody who is on this call, but not a clinician, but I would like to just say before we end that healthcare is difficult. Healthcare, I think, in these times is even more difficult. But healthcare right now, I think, is also more significant than maybe it is at other times. We're all in a place where we definitely need to rely on each other. And although in the United States, for some reason, I do not understand, maybe we don't have as many houses close together with balconies. I know they were doing it in New York, but standing outside at 7 o'clock and sort of applauding and ringing the pots, it's not 7 o'clock yet, but it's 7 o'clock somewhere. So let us all sort of thank everybody for the jobs that you do, and to think about the way in which we really are a community, although we may be a community much in isolation these days. So thank you again, Judy, and thank you to everyone. Good night, everybody.
Good night.